what we're doing is comparing extended full-dose antibiotics coupled with an antiseptic, methenamine hippurate, as a treatment option for patients.
Today, I'm chatting with Dr. Kiren Gill and Dr. Harry Horsley to learn more about the ETAP trial, a new clinical trial investigating extended antibiotic treatment in combination with methenamine hippurate for chronic UTI. Thank you both for joining me.
Thank you, Melissa. Thank you for the opportunity to talk to you about the trial.
There's definitely a lot of patient interest in this trial, but before we dive into the trial itself, I'd love to hear more about your professional backgrounds on your roles within the trial.
Absolutely. So I'm Kiren Gill, and I'm one of the co-chief investigators for this trial, along with Professor Raj Kazria. So a little bit about me: I'm a consultant urogynecologist and an obstetrician, and I've had a clinical and academic interest in UTI, bladder disorders, and pelvic floor disorders. I work at the Whittington Hospital, which is one of the sites for the trial, and then I'm a clinical academic at the Institute of Women's Health at University College London, and I work closely with Harry and his team in the BIGG group.
Great, thanks. And Harry, we've spoken before, but for people who didn't watch your first video, can you introduce yourself?
Yeah, hi Melissa. Thank you very much for having me back again. Can't believe you've done that, but thank you. My name's Dr. Harry Horsley. I'm a PI on this trial and also the scientific lead. I've been researching recurrent and chronic UTI for just over 15 years now, from a scientific perspective. And I myself and Raj Vindicastria, who was just mentioned, lead a group at University College London called the Bladder Infection and Immunity Group, and all of our work is just on UTI.
I'd like to talk about the difference between recurrent and chronic UTI and how those are currently defined. Can you shed some light on that?
So recurrent UTI is quite, I guess, well studied and well defined. So most people would kind of describe that as having 3 discrete episodes of UTI in a year, or 2 within 6 months. And usually in between those periods of UTI, you're quite symptom free, where you don't have any lower urinary tract symptoms. Chronic UTI, however, is probably a newer condition, though, as Harry said, something that we've been sort of researching for several years now. And very much the definition, I think, has come and been derived from patients. So it's and that's the clinical definition that we've used for the trial. And interestingly, this is the first clinical trial that defines chronic UTI and is actually a trial for patients. So the definition that we've used is continuous symptoms that occur on a daily basis. So these can be other storage symptoms such as frequency, urgency, voiding problems, and pain. And then you may get discrete periods where things are worse. So you get those acute flares in between. And we would say persistent symptoms for more than 3 months.
Okay, that makes sense. There are a lot of people in our community who do report having symptoms on a daily basis. When you say daily basis, does that mean 24 hours a day, or just so continuous that you experience them at least every day?
So not necessarily 24 hours, but symptoms that you would experience sort of on a daily basis that you would associate with infection. And the pathophysiology behind that is that we're thinking there's a chronic embedded urinary tract infection that gives you this low grade of symptoms daily, but then you may go through periods where you've got more acute symptoms, or a flare, as patients usually call it.
Okay, thanks for clarifying. Why does it matter that the NHS currently doesn't have specific treatment guidelines for chronic UTI, and what does that mean in practice for someone seeking help?
So I guess the lack of definition and clear guidance makes it really challenging for patients to access the correct care and also the correct diagnosis, which I think starts off in terms of that treatment journey. So without any specific national guidance or clear definition of chronic UTI, it's very difficult for patients to be, one, pointed to the right services, and 2, to access those right treatments. So mainly patients can be misdiagnosed with other associated conditions or conditions with similar symptoms, such as painful bladder syndrome, also known as interstitial cystitis, genital urinary symptoms of the menopause, or overactive bladder in most cases.
Okay, great. That's good to know. Let's chat about the trial now. Who is funding and organising the ETAP trial?
So the funders are the Medical Research Council in the UK, the MRC. Now, who is organising it? the sponsor, because every clinical trial has to have huge oversight. So UCL have the Comprehensive Clinical Trials Unit, which are a very, very experienced unit in dealing with clinical trials. Now, obviously, you have to look for funding to do these things. So led by Raj, who we keep speaking about, myself, Kiren, and a few other PIs from around the country have spent nearly 2 years probably looking for funding to make this work.
Well, it's great that you've managed to get to this point. I know we've been receiving questions for probably that amount of time about when this type of trial will run. So there's a lot of excitement in the patient community that it is actually off the ground now. So the trial is described as a phase 2 trial. For our listeners who aren't familiar with how clinical trials work, can you briefly explain what that means and where ETAP is in that journey towards changing treatment?
Yeah, so if you think about a phase 1 trial, that would be first in man. So that's when you have medicinal product and you give it to people for the first time and make sure that it's relatively safe and nothing horrific takes place. Phase 2 is when you're looking more for safety and efficacy. So not only is it safe, we know the drugs are safe, but is it efficacious in a group of people that we know have a defined problem? So Kiren was saying earlier, the defined problem for the first time is chronic UTI. So we have a cohort of people, and then we test that against people that have a standard of care drug. And the main thing is safety, but the important thing for the listeners or the watchers is that we're also now looking at efficacy. Does it work?
Can you walk us through the 2 treatment groups for the trial and what each group will receive?
Yeah, of course, can. So there are 2 arms to the trial. So Arm A, which is the intervention arm, and Arm B, which is the control arm. So as Harry's mentioned, what we're doing is comparing extended full dose antibiotics coupled with an antiseptic, methenamine hippurate, as a treatment option for patients, and that's the intervention arm. Now, to make this a pragmatic trial, those treatments can include either cefalexin, nitrofurantoin, or trimethoprim that would be taken with methenamine hippurate over a 12-week period. The control arm of the trial looks at the current standards of treatment that NICE advocate for recurrent UTI. So we're using low-dose prophylaxis, which is usually a once-daily antibiotic, either amoxicillin, cefalexin, nitrofurantoin, or trimethoprim, or the antiseptic methenamine hippurate, and that's taken once daily over 12 weeks.
Is the prophylaxis based on the ULTA trial? Or
Yes, correct, yeah. So it's based on the new update of the NICE guidance that happened at the end of last year, which is why methenamine hippurate has been added to Arm B as well.
Yeah, that's interesting. And it was great to see the results of that trial as well, because a lot of patients are interested in Hiprex too.
Fabulous.
Yeah, it's really good. And I've seen it referenced in many other studies now too. So it was really important work, and as will this trial be. So back to the antibiotics, the choice of which specific antibiotic a participant receives is made by their local doctor rather than being fixed. Can you explain why the trial was designed in that way?
We've designed this trial over several years, as Harry has mentioned. And what we wanted this trial to be was pragmatic and patient-led, but also to include as many participants as we can. So as in clinical practice, we would talk to a patient, look at their side effect profile, their tolerability, whether a medication previously may or may not have worked for them. And that's what this allows you to do.
And you mentioned side effects. What are the main side effects that someone could or should be on the lookout for during this trial?
Yeah, so generally, all of these drugs that we're using are very old drugs. They've been around for a long time and generally very well tolerated. But as with any antibiotics, what we're looking for is any kind of gastrointestinal side effects, so nausea, some gastric upset. Other than that, there are some serious side effects, which thankfully are very rare, that are associated with antibiotics. And that's what we will be monitoring all the patients for with regular follow-ups. So with nitrofurantoin, pulmonary problems, or with trimethoprim, rarely hematological or blood disorder problems. Methenamine hippurate, again, has been around for over 100 years. So it's a very well-tolerated drug, but for a small subset of patients, it can give you some sort of burning and stinging when you pass urine.
We get asked almost daily for references to this type of protocol. So it will be really helpful for our work too, to be able to share the research once it has been completed and the results are published. I'm really looking forward to that. The trial is going to use an approach that we've talked about before in your interview as well, Harry, this fresh urine microscopy. Can you explain why that's being used in this trial, or why it's important for people with chronic UTI specifically?
Well, I think the way you've posed that question is interesting, isn't it? Because you've said specifically for chronic UTI, and I think that's the point.
Mm-hmm.
We've spoken about it before, and I know you've had visitors on your channel before speaking about it, but Kiren, tell me if I'm wrong, but the view is, and my view certainly is, that if you have someone who's young, you know, what you'd refer to as sort of honeymoon cystitis, you may well get a single pathogen, a single bacteria growing in huge quantities in the urine. So you put it on an agar plate using the gold standard MSU culture, and they'll likely grow a load of E. coli or a load of something that's a known urinary pathogen over 10 to the 5 coliforming units. Then they'll say, what antibiotic will work on that? Oh, it's probably this, and then they'll have that. And usually, hopefully, most of the time, they'll be okay.
Mm-hmm.
However, when you're dealing with smaller or lower titers of bacteria, or potentially polymicrobial infections, which we're also beginning to prove now as well, there's no reason to suppose that an MSU culture is going to perform very well at all. So when we talk about these recurrent or chronic infections, more likely in later life, the standard technique for detecting UTI is quite poor. And that's very, very well published by ourselves and many other people around the world, particularly in America. So in the clinics that I work with and in the research that we do, we tend to look at urine almost instantaneously under a microscope, and we look for an inflammatory response. So instead of what bacteria there, we're trying to find out if the host, the person, is mounting an immune response. Now, if a person is mounting an immune response in the bladder, by far the most probable cause is an infection. So this allows us to do something fast rather than waiting 2 to 3 days or longer. And it actually looks for a problem with the host mounting a response rather than whether a bacteria exists or not in that niche. And our data is looking very good. And because our data looks so watertight, the MRC have also agreed to use this as a primary measure for this trial.
That's great.
Yeah, it's been absolutely amazing that took place.
Can you explain a bit more about the markers you're looking for that do signify that response?
Really, we're looking at white blood cells. Now, there's loads of different types of white blood cells, but in the bladder, you're usually looking for neutrophils. So we have a grid. I think we're going to do a follow-up on this, aren't we? So I can actually show you visuals of what we identify, which I think will be more helpful. Great. But effectively, we have a grid that's calibrated to 0.9 of a microliter. You add a drop of urine, and then we can count all of the white blood cells that are there and also the epithelial cells that are coming from the bladder. And for this trial, for screening at least, for inclusion, we're looking for over 20 white blood cells per microliter. Because we've shown in our data that there's a very, very statistically significant drop between baseline and 12 weeks of treatment.
Are you using any new technology to analyze the urine during the trial?
We are actually, and we're quite proud of this. So me and a postdoc in our group traveled to Finland as we were setting up this trial, and spoke to a company called Grundium, who actually make slide scanners, so biomedical slide scanners, but usually for intraoperative reasons, so usually to find the margins of resected tumours and this sort of thing. So they had no idea what we were doing and why we were going to talk to them. A fabulous company. So we have then modified these units and deployed them at all 5 sites. The idea is that the researchers put a drop of urine on a slide, put it on that machine, it then scans the entire thing. It then seamlessly uploads to a cloud storage that only we have access to, that's very secure at UCL. And then me and our trained team can then analyze the samples, and then we fill in all of the trial documentation. But the other thing is we also work on image-based AI with our collaborators in Germany, and this is going to form the backbone of starting a new test effectively. So as we're using it in a relatively manual way, we're going to use the data from the trial to further validate our AI system for detecting UTI in this cohort.
That is great that you can collect that data during the trial to validate this approach as well.
Yeah, I think as soon as we started thinking about this, we sort of designed that up from the ground, because we were like, this is a perfect scenario to look at trying out new diagnostics at the same time as trying to look for efficacy.
You're also going to be taking swab samples from the perineal area to look at antimicrobial resistance in the trial. Why is the sample collected from that area?
Right, good question. So obviously, during this trial, when we get urine samples, we'll be doing microscopy. We'll also be doing a standard urine culture. And when you do the standard culture, you look for, you do disc diffusion antimicrobial resistance tests as well. So we'll see how the bacteria in the bladder, if their resistance patterns are changing. However, what that doesn't tell you is any other niche in the body. So obviously bacteria is everywhere, and it's transient through your gut and on your perineum. The idea with a perineal swab is we'll capture E. coli that's likely from fecal flora, tiny amounts, and as the patient travels through the trial, we'll be using that E. coli as a proxy for antimicrobial resistance at different sites of the body.
Interesting. So, because a lot of trials that we've supported recruitment for have done vaginal swabs instead of a perineal swab. Is there a reason that you would choose one rather than the other? Is it because of the gut, the closer link to the gut microbiome?
That's what we were going for, yeah. So, and also there's a few other very high profile trials that did the same, and they're our friends. And the lovely thing is about the scientific community when we're doing these things is we do look for what other people are doing, and we felt that looking at what's happening in the gut is more indicative of the vagina, probably, because usually in the vagina you're going to have a lot more lactobacilli. Their antimicrobial properties, or their resistance properties, sorry, aren't so interesting, whereas something like an E. coli in the gut is very telling.
The fact that you're doing this testing for antimicrobial resistance, does that mean that participants should be concerned about antimicrobial resistance if they join this trial?
No, I don't think so. I think the evidence shows that the chance of it happening are incredibly low. I think we're doing it for safety, and we all have to be very careful about it, obviously, because no one wants to be using lots of antibiotics.
Yeah.
However, the chance of it having any long-term effect, I think, is incredibly low.
Oh, that's good to know. So let's move on to the participants themselves. Who is eligible to participate?
So the trial is open to all participants over the age of 18 who are assigned female at birth. As we spoke about earlier, they need to have sort of persistent symptoms for the last over the last 3 months. So daily urinary symptoms that are usually associated with infection. Also a high white cell count in the urine at screening. So we've used a cutoff of 20, and Harry's kind of described how we would sample that and look at that. We also want to check that there is no baseline kind of problems with the renal function. So we've used a cutoff of an EGFR of over 45. Also, participants need to kind of not have any structural problems of the urinary tract, or be catheter users, or any medication that may make them more prone to recurrent UTIs. So there are certain diabetic drugs or immunosuppressants as well.
Do you think if this trial is successful, you might then do further trials in some of those other subpopulations? Because it does feel like, and we hear this from the patient community, people with complications are often excluded from trials. And so they then feel like they don't have any treatment options.
Absolutely. And I think we very much are aware of that in the kind of medical world, that actually we use trials to help support treatment guidelines, but actually those treatment guidelines exclude a huge amount of people. For example, kind of pregnant patients, or people that are more prone to getting those UTIs, like your diabetic patients or patients on immune suppressants. So there's always a balance in terms of trying to get the answer to a question when you're doing a trial, but also be mindful that actually that's for a subset of people. And then from that, we can kind of infer or see how this would work in other trial groups. But I completely agree with you.
Very much so, actually, on that point. Yeah.
Yeah, and it's good to hear that it's always been thought about. I think it doesn't often feel that way from the patient perspective, and we often hear that feedback that some patient populations are just excluded from everything, and that means that they feel like at a loss of what to take to their doctor if research doesn't apply to them. But what does that screening process look like, and how long does it take?
So we have so a screening appointment would be about 45 minutes to an hour. So we've got sites across the country in the UK. We have 5 sites that are part of this trial. So we've got the Whittington Hospital, which is in London, along with University College Hospital London and Guy's and St Thomas's, and then Manchester. St Mary's Hospital is another site, as is Newcastle as well. So all our trials information is available on the clinical trials networks, and patients can invite in and let us know that they're interested on our research website email. We would then send them out just a pre-screening questionnaire that they can complete, and then invite them for the screening visit. Now, in that visit, you will meet a clinician and a doctor and a research nurse. We take a thorough history. We do a medical review and examination. We also would consent them for the trial first to make sure that they're happy and go through kind of what it involves. We then take a urine sample that we test for pregnancy, and secondly would then send off to UCL for the urine microscopy to see if they're eligible. We then do a set of baseline blood tests just to check that renal function, liver function, full blood count, calcium and a few other markers such as CRP are all normal. Check what medication somebody might be on, and then sort of take it from there. Now, if they are screened positive based on kind of the history, examination, baseline blood tests, as well as the urine microscopy, then we would invite them back within 2 weeks to have their first baseline visit.
Okay, that's quite a short turnaround. And just to clarify, can a patient self-refer to this trial, or do they need a referral from their GP?
So for some of the sites, so the Whittington and UCLH, you can self-refer. Other sites do, just because of the way funding works and access to hospital clinics, may need a referral from their GP, or we can refer from an alternative site.
Okay, so we can put the link to the trial site in the video description so people can find it more easily and get more information about that. Can you explain what happens once someone is in the trial and how many times they might have to visit the sites?
So we'd have visits at baseline, then at 4 weeks, 8 weeks and 12 weeks. We would kind of just, as we did in the first screening visit, check that nothing's changed in terms of their medical history or their medication. And then we would do some baseline blood tests. That's done at every visit, and that's partly because we're looking at the safety of the extended antibiotic use that patients are having. We fill in some baseline questionnaires at the first visit, and then at the last visit, and take urine samples. The perineal swab is done at the beginning at baseline, and then again at the end of the trial as well.
Great. And will there be any costs to participants for travel or time off work or anything else out of pocket?
We try our best with all trials that there is no cost associated for patients, but there will be the travel cost, which we can reimburse up to £45, and all clinical medications are provided from the hospital.
Okay, that's good to know. And what happens during the trial if someone experiences a UTI flare or worsening of symptoms between their scheduled visits?
Okay, so the trial sites would like to know about it, and we have sort of a 24/7 service available where they can notify us. We would speak to participants either remotely or ideally face-to-face, and if they are having a flare, be able to prescribe for them and treat appropriately. And then once that flare is settled, we can go back to the trial medication.
Okay, so they don't get excluded from the trial if they have a UTI during that time?
No, so part of the trial, because we wanted it to be pragmatic and real life, patients who have UTIs do have flares from time to time. We've got clear guidance on rescue therapy should you be either on the intervention arm or the control arm and have a UTI flare.
Okay, are they allowed to take anything else that they might usually take if they have symptoms, such as Demonose or cranberry or other supplements or vaginal estrogen?
Yes, so we would take a note of all of those and make sure that those are documented both in both arms of the trial, but to make this kind of pragmatic and also representative of what UTI patients do experience and treatments that they use. They can take Demonose, can take cranberry and vaginal estrogen.
That's really good to hear because a lot of patients would hesitate to join a trial if they can't do what they usually do to manage their symptoms. So I think that's a really important approach. How will you measure whether one treatment is better than the other in terms of outcomes?
So going back to the urinary white cells, that's
Hmm.
our primary endpoint, which is actually very exciting for us because we know it works.
Hmm.
So between effectively their baseline visit and their 12-week visit, has the white cell count gone up or down? Hence a urinary inflammatory marker.
Hmm.
But then as our secondary outcome measures, we have obviously accredited symptom questionnaires, quality of life, drug adherence, antibiotic resistance patterns, their satisfaction, and obviously we also have all the MSU results as well. So it's a very, very comprehensive bank of data. But the primary endpoint is the change in white cells.
Okay, and if the trial does show positive results, what would that mean in practical terms for the chronic UTI community? For instance, might it change NHS guidelines?
We're definitely hopeful of that. I think this is a huge step in the right direction. This is the first trial, RCT randomized control trial that actually is specifically for chronic UTI patients, and the first trial that actually has a definition of what symptoms may be in that group of patients. And I think this is a really important starting point to have that discussion about what is chronic UTI and how do we treat it. So definitely, I really hope that this will influence a good change in terms of NICE guidance and be able to, one, help clinicians in treating patients appropriately, and also open up the door for different treatment options for patients.
Definitely. When do you think you might have those results or be able to publish anything from the trial?
Yeah, so it's super exciting. This trial is now open to recruitment with 2 sites open already. So the Whittington Hospital and also Newcastle are both open to recruit.
Great.
We should be opening the other 3 sites imminently and shortly. Those would be St Mary's Hospital in Manchester, University College London, and also Guy's and St Thomas's Hospital. So all of that information will be available on trials.gov as all the trial sites open. So please keep a lookout for that. Recruitment is due to finish in August 2027, and we are really hopeful to have the first results published by early 2028.
Okay, great. We'll be keeping an eye out for that. I'd love to hear some updates as the trial progresses as well. And there'll surely be more questions from the patient community about it, but I really hope it goes well.
Thank you so much.
Okay, thank you, Melissa.
Thank you both. Thanks so much for watching. I hope you found this expert video helpful. If you'd like to learn more about this or related topics, be sure to check out our other videos or head over to liveUTIfree.com for related articles. We'll drop some links in the video description. If you like what we're doing on this channel, you can support our work by hitting subscribe here on YouTube, and don't forget to tick the bell so you'll be notified of our future videos. Thanks again for watching, and until next time, keep asking questions and pushing for better solutions.